My name is Stuart McGill. I'm a professor, emeritus now. I've retired from the university, but you are listening to the Physical Performance Show with Brad Beer.
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to another episode of the Physical Performance Show, brought to you by the Gold Coast Marathon and Pogo Physio. I trust you've been having a great week, and I hope that you've been enjoying pursuing your physical best performance. This is a special expert edition of the Physical Performance Show, where I bring you conversations with world-leading experts and authorities in the health and fitness space. And on today's episode, I share a conversation with you that I had with Professor Stuart McGill. On this week's episode, we talk through all things lower back pain, and there is no one better credentialed on this planet than today's featured guest, Professor Stuart McGill. By way of bio, Stuart McGill is a Professor Emeritus in Spine Biomechanics from the University of Waterloo. For 32 years at the University of Waterloo, Professor McGill directed laboratory investigations that explored lower back pain function, injury prevention and rehabilitation, and performance training. Professor McGill's collective work resulted in an incredible 400 scientific publications that included 4 textbooks. The first book, Lower Back Disorders, Evidence-Based Prevention and Rehabilitation, now up to its 3rd edition, was written for clinicians, like myself as a physiotherapist, to guide their decision process when prescribing prevention and rehabilitation approaches. Another textbook, Ultimate Back Fitness and Performance, now up to its 6th edition, was written for trainers, coaches, athletes, and those interested in enhancing the performance of their back while minimizing any loss of resilience. Now, I must say, this textbook was the first book that I actually purchased when I became a graduated physiotherapist, and it's a book that I still refer to 12 years on. In more recent times, Professor McGill was asked to write a book for the lay public, and this book, titled Back Mechanic, The Secrets to a Healthy Spine That Your Doctor Isn't Telling You. In this book, Professor McGill outlines a step-by-step method to help readers fix their back pain. And then most recently, Professor McGill paired up with champion powerlifter Brian Carroll to author The Gift of Injury. This book guides the strength athlete out of pain and back to regaining strength. In addition to Professor McGill's many scientific papers and his contribution to the science around all things back biomechanics and lower back pain, Professor McGill also acts as a consultant in difficult back injury cases and provides performance enhancement programs for individuals and teams alike. Professor McGill has worked with countless Olympic champions from around the world in a variety of sports, as well as elite athletes in the NBA, NFL, PGA, NHL, and UFC fighters, amongst others. Professor McGill has also been sought out by presidents and Hollywood celebrities to help them get back to their best lower back fitness. As a physiotherapy student way back in the early 2000s, I was learning about Professor McGill's lower back research and how it applied to the clinical setting. It really did pave the foundation for how, when I first graduated, I approached lower back pain. My interest in Professor McGill's work was not just professional in helping my patients, it was also in helping myself. For many years at university, I suffered from discogenic lower back pain that was very debilitating. In fact, there were days where I thought I would not even be able to finish my university degree. This early experience with back pain certainly developed within me a great interest in how lower back pain needed to be managed to help people get back to their physical best. If you had told me as a university student that at one point in my career I'd have the opportunity to speak directly with Professor McGill for the generous time that he shared with us, I would have said you were joking. This expert edition goes for around about 90 minutes, but if you yourself have ever suffered from the debilitating effects of lower back pain, or you know someone that has, then they're going to want to devour the wisdom that Dr. McGill shares in this expert edition. In this episode, we get very practical. We talk about what lower back pain actually is and what are the common conditions that we can experience across the lifespan with our spines. We discuss why assessments need to be thorough for back pain sufferers. Professor McGill debunks the many lower back pain myths, including is stretching of the hamstrings of any use. We discuss the concept of core stability, and Professor McGill gives us a true and accurate definition and why he believes it is fundamental to human movement and an absolute non-negotiable for athletic best performance. Professor McGill refers to examples of stifling athletic development through not allowing rest. We discuss the 2.5-year rehabilitation of Brian Carroll, champion weightlifter who succumbed to a very serious lower back and sacral injury, and how Professor McGill helped Brian return to competition, an environment where he became the first man to squat more than 50 times in competition, a weight greater than 1,000 pounds. It's an incredible example of a very nasty injury and should give anyone listening hope that they too can look forward to enjoying pain-free best performance from their lower backs, no matter what the degree of injury is that they may have incurred. We touch on why it's important for lower back pain sufferers to determine if they're able to have a good day in amongst the bad days. Professor McGill shares with us his big 3 non-negotiable exercises: the McGill curls, the bird dogs, and the side planks. Finally, we talk about why Professor McGill does not believe that drawing in activating transverse abdominis is of any use when it comes to creating stiffness of the spine. And finally, if you are a sit-up or a crunch lover for your abdominals, we discuss why it is fundamentally doing you harm if you are performing crunches for your spine, that is. There's a whole lot in this episode. Yes, I was absolutely in my element speaking with this incredible connoisseur of knowledge when it comes to all things lower back pain health and ultimate performance of the spine. Just before we throw to Professor McGill, be sure to jump over and check out the video that was recorded at the time of recording this episode with Professor McGill over on the show notes at pogophysio.com.au. Professor McGill uses many models to show and explain the concepts that we refer to throughout this interview. So if you'd like to see the visuals, then jump over and marry up what you've heard through this episode with the videos that were captured via Skype, and they're living over at pogophysio.com.au. Let's hear from Professor McGill. And just before we start, you might want to grab a notepad and pen. Listeners, this for me as a practitioner of 12 years, a physiotherapist in Australia, is a real thrill. I'm really excited and secondly honoured to be able to spend time bringing you a conversation with Professor Stuart McGill, without doubt one of the world's preeminent minds around all things lower back pain and certainly spinal biomechanics. Professor McGill, thank you for joining us.
Thanks so much, Brad. And we did have a little bit of a preamble over the past few minutes. So from here on in, please, I'm going to call you Brad if you call me Stu.
Stu, I did mention in the preamble that you just referred to that your publication, The Ultimate Back Fitness, it was the second edition. I purchased it in 2006. I think it cost $90 Australian, and it was one of the best investments I made early in my physiotherapy professional career in terms of how I approached back pain. So a big thanks for kicking me off in the right direction. And I know that was 2006. It's now 2018. We have quite a few years to catch up on.
Thank you for funding my retirement and making it possible.
Oh, look, brilliant. So, Stu, put listeners in perspective just a little bit about the man behind the professor, behind backfitpro.com, the moustache, the glasses, the icon. A little bit about your history, why you got into the field you got into, and what your world currently looks like after heading up 32 years of professorship there at Waterloo University. So a little bit about you first.
People will occasionally ask me to come in and do a talk on how to plan a career. And I say, please don't do that because I'm the worst example in the world. I never in a million years thought I would end up being what I am today. I was always interested in sport, and I must admit it was sport that took me to university. I was never even going to go, but I went because I was interested in playing football, believe it or not. But I morphed into, for my master's degree, I was into road cycling at that time, and I chose my university to do road cycling in the Gatineau Mountains of Quebec. And then for my PhD, that all happened basically around a hockey game. I met a professor. I was playing hockey with the professor's team of University of Ottawa, where I was taking my master's, and we played the University of Waterloo, and I met Bob Norman, who was a professor just starting spine biomechanics, and he said, "Oh, come and visit the laboratory." I was starting my PhD in systems design engineering, and I switched over to spine biomechanics. So I did become a professor quite young of spine biomechanics, and obviously I was trained as a scientist, and I would get asked to go to different neurology and orthopedic clinical meetings, and I would describe our latest findings of how the back worked and became injured and created pain and these sorts of things. And the docs would say, "That's very interesting. We don't look at things that way. Would you come and see a patient with us?" And I said, "Well, no, I'm not trained as a clinician." But slowly I did attend with them, and I realized very quickly that how they were trained actually impeded what they saw. So I would come in tabula rasa, and I would say, well, that pattern, we recognize that from our laboratory as this mechanism and manifestation of pain. And I learned right away we had something unique. So we eventually ended up opening a experimental clinic at the university, and every back pain person we saw was the failure. They'd already been to a dozen different clinicians, be it a chiro, a physio, an orthopedic surgeon, the psychologist, the pain clinic, etc. And we treated each one as an experiment. We would probe them and explore them and try and understand the pathway of their pain. And the other unique thing we did was we tracked our success rate. With every patient we saw, we followed up. So we knew who we did well with and who we didn't and why and what they were given and that kind of thing. But it was a great synergy. We didn't really, again, it's partly my personality, I suppose, but we didn't really pay too much attention to what other people were discovering in the spine world. Instead, we would look at the athletes who came in, who were the epitome of excellent human performance, but they would have pain, or the very tragic bad back stories. And when we couldn't answer or solve the puzzle, that became our next experiment in the lab. So we bounced back and forth between the clinic and laboratory, and those we didn't test hypotheses or follow the usual format of a scientific laboratory. It was all driven from the clinic, and that's a rather unique approach in the world, and it's, I guess, how we arrived at the position that we're at now. I did retire from the university, and You're actually in my home. Backfit Pro headquarters is in Gravenhurst, Ontario, and mostly athletes, but difficult back pain cases as well. They fly in, and that's my life now. I see a few patients, and it's the same process. They're challenging cases, and we spend a great effort in assessing and understanding the mechanism of pain, so we have a very specific target to create the desensitization, wind down their pain, and then build them all back up again to have some pain-free activity potential. So that's the story. It's a bit long, I suppose. Sorry about that.
Well, Stuart, I think Dr. McGill, it's a difficult one to condense into 2 minutes when it's an outstanding 32-year career with hundreds of scientific papers and obviously multiple publications, including your recent works, which we'll talk about as we go. You're very obviously humble, one, but secondly, obviously, there's the medical patient confidentiality. And, it's well known that some of these people you mentioned that do fly in to seek your expertise are, some of the world's most outstanding athletes in the UFC, politicians, probably even presidents, I believe, might be there, Hollywood stars. So certainly you are so well sought after. And looking at what I know about how you go about things, obviously there's a reason for that. So Stu, let's jump into some real practical things here if we can. And that would be, let's start with back pain 101. What is back pain? And Stu, I've got to call you Dr. McGill, Professor McGill. It feels too informal not to, and we're talking about clinical things here. But what is back pain, and what are the structures that can actually elicit pain?
Well, at the highest level, back pain is caused by activity that creates stresses in the body. And those stresses can cause pain to the point of disability, so that the person now is unable to do something. Now, that might be the ability to go to work. It might be the ability to be a parent to their child. Or if you followed our recent study, we did the first study ever on coitus or sex. And I'm sure you, as a frontline clinician, have had couples come to you and say, last time we had sex, we knackered our back so badly, we are fearful we've been celibate for half a year. And there are no clinical guidelines that exist to guide clinicians like yourself. So recognizing that as a clinical deficit, we studied couples in the laboratory. And you can imagine the sensitivity that had to be exercised throughout all of this and the ethical process. But our goal was to create an atlas that we could then give to the clinical community. And if a patient was flexion movement intolerant or extension movement intolerant or compressive load or shearing load intolerant, we would then say, good, now look up on the atlas, and here is a position and movement that doesn't trigger that particular specific pain trigger that we've now measured and documented in your back. And so this was a game changer. So there's just an example of understanding the pathway, the very specific pathway. And I know I get quoted a lot by saying pain has a reason. All this notion that pain is non-specific back pain, that only shows the person has not had a thorough assessment yet. But when they've had a thorough assessment, the pain now is very specific, and you can target. First of all, it's not a matter of doing exercises. It's a matter of taking away the offensive trigger, the thing that is creating the repeated stress. I'll give you an example. If I had a sore thumb, if I kept bending my thumb over and over again, it would only become more sensitive and more sore till the point that I lightly touched my thumb and I would go, of course I display pain behavior. But when we stop stressing the pain mechanism, the thumb settles. And then after 2 or 3 weeks, we can start moving it and having fun with it. So I don't know why this same story and understanding doesn't exist with back pain. I've never heard of non-specific leg pain. Have you? You know, you either have a fractured leg, or you've got torn knee ligaments, or you've got vascular claudication or something. Figure out what's going on with your leg and address a target. This is just what we must do with backs. So I don't understand this movement that has led to this notion of back pain being non-specific and in people's heads and all the rest of it.
And I'm so pleased, as a clinician speaking here of 12 years, who suffered discogenic lower back pain through my early 20s through really to my mid-20s, quite disabling. I at one point thought I wouldn't be able to finish my physiotherapy degree because I couldn't bend over a treatment table. And I lived through that. Now I'm 37. I haven't had back pain for 10 years. But it never resonated well with me when I was being instructed at university that the diagnosis was non-specific lower back pain. I'm often sitting there in a lecture theatre thinking, I'm in back pain. I have back pain right now, and please don't insult me by telling me that it's non-specific. There's a structure in my back that is causing me pain, and it's going to be one of the, and I need to know what it is.
It's just so interesting to hear this, because there are those people who claim, don't describe the mechanism of back pain to the patient because they will become fearful and afraid of movement and think their back is falling apart. And yet, when I explain the mechanism to the person and then give them a strategy to reduce the pain trigger, and then they say, wow, I just did that with no pain. I'm in control. I'm empowered. All the fear goes away. They gain confidence, and they'll say, Professor, you're the first person who hasn't treated me like a 5-year-old. Thank you. You've recognized my intelligence as a human. I now have a very clear roadmap and strategy to beat this, and I'll stand by my record on that.
Yeah, and certainly it mirrors a bit of a movement as well. Certainly in Australia, I'm not sure what it's like Canada, the US, but about imaging for lower back pain. There's very much a push from the government, Medicare, that lower back pain doesn't do well if it's imaged. Yet my defense to that is I disagree, because it's contextual to how you then talk about the findings and the assessment, looking for their pain triggers. It's not the image. It's not that's the problem. It's what the clinician does to educate and empower the individual. And I second what you have experienced over your amazing career, and that's that it's more liberating for a patient or someone, a back pain sufferer, to have a good, thorough understanding and context, as opposed to not feeling like they were assessed thoroughly, which certainly as a clinician I think is the greatest disservice we can do to anyone that ever comes to seek our services, is not assessing them thoroughly.
Well, I couldn't agree with you more when it comes to the use and misuse of MRIs. It's so prevalent for a radiologist who's never seen the patient, and yet they write in the report this person has DDD, degenerative disc disease. They don't have a disease. What a horrible thing to label a patient, and then they hear that they have a disease. Think of the people who come to you and say, I've got a degenerative disease. They don't. They have had a mechanical insult to their back, and they've let a little bit of height out of the disc, and the structures have changed. I've got models upon models. These have all been made by a company called dynamicdiscdesigns.com. I've got nothing to do with the business, but they model a lot of what we've documented over the years. So, I'll look at an MRI, and we always find a reason for what we have measured in the assessment. I'll be at an international spine meeting, and the surgeon puts an MRI up on the screen, and he'll say something like, as you can see, there's no reason for the person to have pain. And I'll be sitting with another biomechanist. I remember being with Michael Adams, a great disc biomechanist from England. We're sitting in the audience, jumping up and down. Sir, there's a massive fracture on the end plate up there, and you can't see it. But anyway, if I load that in compression, I don't know if you can see that, but do you see the end plate opening up when I squeeze? So that's a compressive kind of injury, but you have to know what you're looking for in order to see that on the MR. If I take this model and I bend it forward, you can see that the delamination in the collagen is closed, but when I bend it forward and flex it and squeeze it, can you see the nucleus bubble out and press the nerve root?
Yes.
And yet when I stack the spine nice and tall and squeeze it, the hydraulics keep the fissure closed. So the point being, the MR is a full history of that person's loading career. In other words, you're looking at all of the wounds of their life and all of the scars. The wound might be 2 weeks old, but the scar might be 20 years old. So someone will see a feature on an MR and say, well, it's not related to their pain. Of course it isn't. It happened 20 years ago. That pain is now desensitized. But when you've seen the patient and you've discovered here is their pain pattern, oh, now we've just found the mechanism confirmed on the MR, it becomes a very powerful tool. But you had to have seen the patient to interpret whether it's a wound or a scar and the full mechanism. And then I'll just show you another quite potent driver to pain. So on this particular model, you can see these facet joints are a little bit angry on the back. And the reason is 2 or 3 years ago, this disc lost a little bit of height and turgor because there was an end plate fracture. But now I'm going to push it from Now, I don't know if you can see that, but the majority of the motion is taking place just at one joint, the joint that has had a little bit of damage. You know, as an orthopedist, if you do a drawer test on a knee where the knee ligaments have been compromised, you get a positive shear at the knee. Well, there's a shear test for the spine, and you can see right there that, or if I did a twisting perturbation, you see the majority of the motion occurring at that level. Well, guess what? And 2 years later, the facet joints, which are now taking an overload of stress over time, they become painful. So, you know, we have this cascade that took 2 years. Yep. And then we have to listen to these people who call themselves pain scientists. Oh, the pain should heal within 12 weeks. Anything after that is psychological. They didn't understand that changing the mechanics of the disc then changed the mechanics of the entire joint. And now we're into a 10-year cascade of pain. But when you know these things, we don't have to default and insult the patient by saying the pain is in your head. We actually quite understand why you have a very specific pain, and here's a strategy for you.
Professor McGill, that just makes sense. I mean, it's just in my mind, it's always been your work's a commonsensical approach to what is a very real condition involving certain structures. Before we talk a bit about assessment, if you could just cover, you know, the back conditions that you often see relating to people through their life cycle. You know, there's certain conditions that will be more prevalent at different stages. Could you take myself and listeners through a typical journey of a spine over the decades?
Absolutely, yes. Let me see if I can pull out a couple of models here. Just let me reach for another one if I can.
Certainly.
Well, first of all, when we do an assessment, the first thing we assess are specific motions, postures, and loads that trigger a person's back pain. So you will recognize a very common pattern among younger people because you did an introduction about this. You are a young physio student with discogenic pain. How many people in their 60s do you know with discogenic pain? You see, it's very, very rare. So discogenic pain is an overload to the disc, and basically from a mechanical perspective, the hip joint, for example, is a ball and socket joint. It is made to create power and force through a very high range of motion. The joint is built to create that. However, a spinal disc is not. It's actually a collection of collagen fibers, layer upon layer, and the fibers are held together with a ground substance. In other words, it's a fabric. So if I wanted to work a hole in the fabric of my shirt, I would simply stress it. And those stress-strain reversals back and forth would slowly work the fibers apart. So too much motion, and then another curious feature of the disc is it's filled with a nuclear gel in the middle, which pressurizes when you load your spine and play sport and lift your child out of the crib and all these kinds of things. If the collagen becomes delaminated by too much movement, and then you stress the gel, it can then slowly work its way through the delaminations in the fibers. So that is very much a younger person's pathway to pain and a discogenic source. And I gave you the other one, the end plate. The end plate of the vertebra is not bone. It's actually a cartilage. And if you stress it over and over and over again, in excessive amplitude, it will get a micro crack, and you'll lose a little bit of nucleus up into the vertebral body. So these things, if you know what you're looking for, are very evident on MRs. The problem is most radiologists miss. They're very good at looking for tumors and things like that. They're absolutely, as a profession, very deficit in finding these micro levels of evidence that lead to people's pain. So there's a start on younger people's pain. And these things lead to micro movements that I was showing earlier. And if that's the cause of a person's pain, you could imagine I could simply ask them, stand up, go up on your toes, and land on your heels. Boom. And they'll say, oh, yeah, there's my pain. And then I'll say, good, push my fingers out. And they push their fingers not forward, but push my fingers out laterally. Now I've got a little bit of a stiffness or a girdle around that micro movement. Now repeat oh yeah, my pain is gone. Good. We've arrested the micro movement, we've stiffened the joint, and we've now given you a proven strategy to reduce the offending pain trigger. But as a person ages,
Stu, if I could just quickly, Professor McGill asked there on the younger, just because it's such a good illustration there, the delamination of the wall of the disc, the key movements that repeated that could stress that, are we talking about flexion-based or bending, rounded back, sitting in the university lecture? Is that
all of that?
All of that.
All of that. So it's so interesting. If you are a lifter, so say you're a young student, you sit at lecture, and then you go and train in the weight room for a little while, almost always the common pattern is to have a posterior pattern to the disc delamination. So it's almost always a posterior disc bulge.
Yep.
And when you bend forward, the nuclear gel hydraulically is pushed through the delaminations. But now I'm going to give you an example where bending forward takes a disc bulge away. Those aren't in the lifters and the people who train in the gym. Those are in the yoga masters.
Okay.
So those people who just do high mobility work of their spine, and they do it excessively and create sensitization, when you look on their MRIs, the typical pattern is they have very plump discs. They haven't stressed them in compression. But when they bend backwards, their disc bulge increases. And then when they bend forward, the disc bulge goes away, which is the opposite of the delamination pattern of the young person who weight trains. So again, you can see why there's subcategories within subcategories if you've documented the mechanisms and recognized some of these patterns. So there's just an example. But as you age, because of the laxity in the joint now, and the loss of turgor and the stiffness that guides normal motion, the body's response is to grow some arthritic bone. So this is a model taken from a spine now that has a bit of disc damage, and you can see the arthritic bone growing around the margins of the vertebra, and they grow around the facet joints now, so that the facet joints start to get angry. So years ago, the patient got pain triggered from bending their spine forward, but now they're getting it from walking. Walking used to take their pain away, but now it increases their pain as the body's reaction has to create some arthritic bone posteriorly. Now, I'm going to take this particular model, and you'll see it's moving very well, but this joint now has become a little bit arthritic. These are all real anatomical casts, by the way, taken from real spines. But watch what happens when this person was younger, they had no pain generating from the facet joints at all. But now they're going to extend. I'm going to extend. Now watch. This joint keeps moving. This joint now got bound up. The arthritis has now locked the facet joints together. Watch, I'm just going to pop it apart. So there's an example of someone's pain now driven from movement that is no longer discogenic. It is actually the facet joint grinding, just like an arthritic knee would behave or an arthritic hip. So there's a little bit of a cascade through the ages for you and some typical patterns that, once again, when we document these in the individual, we then give them a strategy to stop the stress that is causing that continuing pain sensitivity.
You're listening to an expert edition of the Physical Performance Show with Professor Stuart McGill, 32-year Emeritus Professor of Waterloo University, back biomechanist and world-leading authority on all things lower back pain rehabilitation and ultimate performance, share around all things lower back pain. Support for today's show comes from the Gold Coast Marathon. Just like the Physical Performance Show, the Gold Coast Marathon encourages runners of all ages and abilities to push their boundaries and strive to complete a personal challenge. The Gold Coast Marathon is held annually on the first weekend in July and is a must-do event for any budding athlete, weekend warrior, or family looking for a challenge to complete together. Run for the good times at the Gold Coast Marathon. Visit the goldcoastmarathon.com.au webpage for more details today. Support for today's show also comes from Pogo Physio. We exist to help you get back to your physical best following injury. We want everyone who walks through our doors to cross their physio finish line. That's where we high-five you and tell you that you have finished rehabilitation and celebrate you being back to your physical best. In addition to traditional session-to-session appointments, we offer some industry-first models of care, including our unique 2, 6 and 12-week fixed-fee, unlimited access finish line programs, which include unlimited hands-on therapies and supervised exercise rehabilitation, including clinical Pilates, strength and conditioning, and use of state-of-the-art equipment such as the Alter-G anti-gravity treadmill. In addition, our monthly fixed-fee wellness booster packages will help you save money and recover faster. Wellness boosters include remedial massage, physiotherapy, active rehabilitation including clinical Pilates, and start from a low $195 per month health fund rebatable. To find out more, jump over to pogophysio.com.au and schedule your initial appointment today. Now let's jump back to Professor McGill on all things lower back pain. Professor McGill, before we talk about assessment, what would you say? I mean, this is it's a big question, but are the top 2 or 3 myths about back pain? I mean, one's obviously that it's not in people's head, it's not non-specific, but what would be a couple of other key ones that really bother you and you feel affect patients' outcomes or the public's outcomes, back pain sufferers' outcomes?
Well, I guess there are many. The first myth is that pain is non-specific, and if it lasts longer than a certain amount of time, it's in people's heads. What a terrible situation, and actually driver of a great amount of psychological dissonance. So that would be a huge one. It's so interesting that people who claim this don't assess a patient's back pain. Yeah. And if they would just do a thorough assessment, all of this would go away. Stretching will take away back pain, or I've got tight hamstrings. Therefore, if I stretch my hamstrings, my back pain and my tight hamstrings will go away. Interestingly enough, that when we measure tight hamstrings in a person with low back pain, more than half the time it's not tight muscle, it's a tight sciatic nerve because of it being irritated at the level of the lumbar spine. So the sciatic nerve comes from the roots of L4 and L5. These two form a plexus that goes behind the hip and down the back of the thigh. And when there's, it's usually discogenic in younger people, they get the perception of a tight hamstring, and you will not stretch away that type of pain. What they will do is stretch the muscle reflex, which gives about 20 minutes on average period of time of analgesia. So it feels good for 20 minutes, and then it comes back even tighter after that. So when we recognize that particular pattern, we would then instruct the patient, I know it feels good to stretch your hamstrings, but think of it, you have to stretch them again in an hour. And they say, yes, this is correct. Stop stretching them. Settle them down. Practice the principles of spine hygiene, and let's start addressing the cause of why you have tight hamstrings. And now they will say, I haven't stretched for 2 weeks. My back pain and my perception of tight hamstrings is lessening. Fabulous. We're well underway now. You could give me some myths as well. Well, here would be another one, and I've well documented this. Let's take the typical scenario of a patient who says, or who's been told, you've done physio, you've done chiro, you've done this and that. The only remaining option for you is surgery. So out of all of the patients that we've had over 30 years that fall into that category, they come to see us, we've been told our last option is surgery. We get 95% of them, that's 19 out of 20, to avoid surgery, and they're happy for it. Because not once in all of those great professionals that they saw had they received a thorough assessment. So once we did the assessment, documented the very specific pain pathway that they had and addressed it, they were able to wind it down. Well, then there's another myth, I suppose, that, I have to find a great clinician to give me an assessment. Not really. When people follow, now I'm not trying to sell things here, but I wrote books for a reason. Yeah. As you know, I wrote books for clinicians, and never in a million years did I think I'd write a back pain book for the lay public. But people kept asking me, and then book agents would come, would you please write a book for the lay public? Well, it was the hardest thing I ever did, to maintain the scientific integrity, but still make it simple enough for people to consume. So that's this book, Back Mechanic. In Chapter 6, I take people through a self-assessment, and I tried to whittle it down to 9 tests. And based on their pain triggered by those 9 tests, they can put themselves into a subcategory. So they will find out maybe they're extension intolerant. Good. Here's the strategy to follow. Maybe they're flexion intolerant. Maybe they're shear load intolerant. Maybe they're compressive load intolerant. Whatever it happens to be. And believe it or not, it's a myth that people can't self-assess. In fact, with a little bit of guidance, most people are quite successful. Now, there are those that might have 2 or 3 concomitant pain drivers. Good, there's a bit of complexity here. They're not faking their pain. Yeah. They have inconsistencies because of a reason. So those people need to come and see you. So these are the people now. They're a bit puzzling, but I hope the clinician they go to then performs an expert assessment and really guides this person with a very specific strategy. So there's a few myths that come to mind.
And Professor McGill, I mean, they're wonderful, and we're going to throw to the assessment, and you just touched on some of the self-assessment that comes out of your recent book there, Back Mechanic. But the 2 myths that I think I hear it from the consulting room the most down under here in Australia would be, now I've got a bad back. And I normally encourage people that, look, I tell them my story. I was a 25-year-old university student who couldn't bend to put my shoes on, and now I'm 37, haven't had back pain for, a decade. And so, no, you do not now have a bad back for the rest of your life. You have a sore back and you need to take action, get fit, get strong. But, you can get there. And the other one would be the real notion that I've put my back out. No, there's no harm in that. That's just how people describe it, because that's what it feels like. But, I often sort of in the treatment room will say, if I could just poke your back and push your back in, I would do that right now. But unfortunately, it's not the reality of what happens. We now need to identify your underlying drivers, contributing factors, get you fit and strong, and do the process. So I'd say they'd be the 2 biggest myths that I hear. Would you have anything to add to those, Professor McGill?
Well, I will stand by my record for restoring athletic careers. I've had hundreds over the years of Olympic athletes from many, many sports. Top sportsmen from the world of golf, the combative sports, Australian football, American football, top-level soccer, cycling, powerlifting, et cetera, and we were able to restore the careers. And if people only knew that there's hope. And this is our latest book that I wrote. It's called Gift of Injury, and you might be able to see the image of this beast on the cover, Brian Carroll. Yep. Brian Carroll was the first person to squat over 1,000 pounds more than 50 times in athletic competition. Here's how Brian Carroll came to see me. So can you see the top MR? He'd split his sacrum front to back. He'd obliterated L5 and crushed his discs at L4 and L5. When I applied those loads repeatedly to a cadaveric spine, you see the split sacrum right here. Exactly, we were able to recreate the injury that he showed up with. This was Brian 3 years later. Magnificent. The bone had all filled in. His discs look reasonable, and he was pain-free, and he is now squatting over 1,000 pounds again. So don't tell me that if you document the mechanism of injury. So there was a case, very specifically, he was told by surgeons, there's nothing we can do for you except fuse your spine, but you'll never lift again. We recognized those nasty fractures. We knew that he would not lift again until we filled in that bone. So we did experimental bone callousing, which is the polar opposite of bodybuilding. I can describe it if you like, but we then worked. And there was no promises in all of this. I said to Brian, I'll show you what I know with no promises, but let's see if we can coach biology to react here. Allow and give the healing the best chance. And we were lucky. And I will say we probably made our own luck to some degree, but filled in the bone, and then he knew how to train as a world-class athlete. So we restored his capacity to train, and then he was off and once again. So again, I will live by my record in restoring these careers in so many sports. So
thank you. And to dig a bit deeper on the Brian Carroll, and I'm itching to get my hands on Gift of Injury through the new Australian distributor. But, you mentioned there this took some time. What sort of time frame was it from when Brian first came to seek your opinion and expertise through to getting him back to, ultimate performance? Are we talking 6 months, 3 months, 18 months, 24 months?
It was 2.5 years for him to carry that load on the platform once again. So again, here was the model. You can see that we dyed the nucleus of the fifth disc blue. So if I pull out the plug and squeeze the spine, do you see the crushed end plate squirting the nuclear material up into the damaged disc? I don't know if you can see that.
No, you can see that.
All right. So you must restore the bone. Well, I'm going to tell a brief story here. Imagine you took a long bone and you fractured it. Every clinician is aware that that bone will create a bony callus over the fracture, and that calloused site of the previous fracture is now stronger to load than the native side that was never fractured. So bone remodels as a function of piezoelectric properties. Let me explain that. So, as a kid, if you were camping at night, you got two quartz rocks, and if you rub them together like that, you get a flash of lightning that you could see at night through the rock. So quartz is a piezoelectric crystal. When you stress a crystal, it builds an electric charge. Your bone, built of charged ions like magnesium and calcium, whatnot, is actually a piezoelectric material. So when you bend a bone, this surface gets stressed in tension, and this surface gets stressed in compression. Well, mostly on the tensile side, as you stress it, it builds a charge at the spot of the highest stress. What that charge does is it sucks in free ions of calcium and magnesium, and it scaffolds it in and holds it in. Now, here is both a myth and a little bit of magic. If you take the typical bodybuilder, the regimen for training is you train 3 days a week, and you let the off days be the adaptation. So you don't train to get strong. You train to adapt. The adaptation takes place in the day off. That's when you get big and strong. Training more will stop that. It will actually create cumulative load to the point of injury and overuse. So the bodybuilder trains 3 days a week, and then bodybuilders try and become power lifters, guys who pick up 1,000 pounds off the floor and these kinds of things. They get hurt. Their adaptation schedule is very different. So a power lifter has to adapt bone. And you'll notice the grand old men and women of powerlifting are setting records when they're in their 30s and even into their 40s, because it took that long to create the adaptation. When you look at their training regimen, quite typically they will have a heavy squat day, to use an example, and then they take 5 days off. So it took 5 days not only to get the piezoelectric effect of laying in the new bone, but then you have to let it scaffold. Because if you're a bodybuilder and you just take 1 day off and you train again, you break off the bone that has just been laid down. It took 5 days to allow the bone to lay in and then scaffold in. So now when you train again, you don't rip off the new. I'm using very lay terms here, but you get the idea. So you have to completely transition your programming to build your body to bear that ultimate load. So in Brian's case, what the experiment was, and I told him honestly, Brian, I've only done this a few times before, but here's what I know. I want you to train and load the fractures very mildly and then take 5 days off. And now do that for a year. So here's why many people fail. They don't have the discipline and the professionalism to follow that instruction. But Brian is a one of those 1 in a million athletes. Yep. And he did that. Now he cheated on the end a little bit, and he pushed it in his rush because he was feeling so well. Cool. Yep. But anyway, there was the story of the bone callousing that we describe in the book, and then he had to strategically build stability and mobility. And if you want to have a discussion about what is all of this notion of spine stability all about, we can do that, because it is absolutely fundamental for human movement and absolutely non-negotiable for any kind of performance. But anyway, we then strategically tuned his body for stability and mobility. I mean, as a power lifter, you don't want much mobility in hamstrings. You want just enough so they're at full extension when he's starting the pull. So you want tight hamstrings, in other words, in that particular kind of athlete. Is he going to be the fastest sprinter in the world? No, but you're tuning an athlete, or you're tuning a Ferrari. You know, a Ferrari can go fast on road, but I wouldn't take it to Ayers Rock in the middle of Australia. It wouldn't be tuned for that. So anyway, I'm trying to contain my excitement here, because now you're into what I love. There's a little bit of a story on bone callousing, knowing the specific mechanism and what we needed to build as the foundation upon which he could then restore his athleticism.
Brilliant. And certainly, listeners, if you want to find out more about Brian's, rehabilitation, then obviously that'll be found in the new publication, Gift of Injury, of which I'll be grabbing a copy of. So you find out more detail there. Obviously, that's a very condensed, description from Professor McGill. One thing I did take from that, though, Professor, is that the key in rehabilitation is not so much the work, it's the adaptation phase, the recovery. And one of the previous guests of this show, the Physical Performance Show, Nick Willis, 4 times New Zealand 1,500 metre track runner, Olympic representative, dual medalist, Olympic medalist, he said something that was so profound at one point. He said, I get ahead when I rest. I don't get ahead when I do the hard sets. I'm getting ahead when I rest. And he said, come an Olympic final, everybody's done the work, but not everybody's done the correct rest. And I thought that was beautifully articulated. I get ahead when I rest.
It's awful when I'm not a social media person. I don't even know how to sign on to Facebook, but my daughter does it. But, I'll be seeing all these macho things that people show me on Facebook and Instagram. Here's what I do on my training day, and then on my day off, I only do 100 kettlebell swings or something like that. And I think these people are so stifling their athletic development. Not one of them will be holding a world record. These are people who train in their mother's basement.
Yeah, and I mean, there's discipline to do the work, but there's discipline to do the work of rest, I believe. Let's move off, Professor McGill, the assessment. I just want to read something, though, from your website, BackFit Pro, because I think this really speaks to anyone listening who has felt like rehabilitation to date has failed them. This is some copy off your website. The key to success is to understand the pain mechanism and address the mechanism. People have failed previous approaches for a variety of reasons. They were given inappropriate exercises, or there were barriers to relief that were not understood and addressed. Success begins with a thorough assessment. A 10-minute assessment from your clinician has little chance to understand why you have pain. And if I just pause there, Professor, I would say one of the pet peeves I have as a clinician is express medicine. I mean, as a practice here, we take at least 1 hour for initial appointment and often 2 separate 1 hour sessions to assess someone comprehensively. I know for you, when you see private patients, you will take up to 3 hours, correct?
It could be a lot longer than that. I take how long is necessary for them to tell me why they've failed in the past. And I can give you many examples, and you'll find this strange. But before we bring them down here and put them on the table and assess their pain and then put them under load and movement and whatnot, we sit in front of a fire. So upstairs is a fireplace that's always going when the patient walks in. They sit on a couch. I sit on a couch, not in front of them, but at 45 degrees. I don't want to get in their face. I want them to look at the fire. I might talk to them for 45 minutes. And for the first time now, someone is listening. Yeah. And they're listening to their story. And I'll say, well, you've been to this clinician who practices some of our approaches. He told you to walk 3 times a day. Tell me about that. And they say, well, I'm not comfortable walking when the sun goes down in our neighborhood. I don't feel safe. Okay, we've just identified a social barrier to their success. What do you think the compliance is going to be if we say, oh, we'll go for a walk 3 times a day, but it happens to be dark after 5 p.m. at night? They will fail. So there's just an example where we need to understand, and people accuse me who've never worked with me that I'm a biomechanist. And I think you really ignorant person who has never seen what we do and how much effort we put into trying to understand the psychological, the social impediments to their recovery, where all the time I'm assessing their learning style. Do you respond to verbal cues? Do you need me to touch you? Do you need me to create a sound or whatever it is to get the movement and the mechanical response I need to wind down their pain triggers? So, or are they a type A personality where someone has said, we'll do 3 sets of this, and they think they're going to beat themselves out of pain, so they do 20 repetitions when they were only told to do 3. Or you get the sloth who negotiates with you right away. I was late for work and I begged off, or something like that. So we're assessing all of this all the time, trying to understand the barriers of why they didn't get better before. So, it's...
And the time factor too. I mean, I've heard you in your assessments that I saw research in. One of the first things I believe you say is, tell me your story. And then you zip your lips and you listen. And that is empowering of the patient, that someone is actually going to take the time and listen to their story. And I heard you, then off the back of that say, tell me about the attempts you've made in the past to get your back better, and why or why not you think they were successful. And so there's so much in there. So thank you for shining the light on the importance of a thorough assessment when people engage health practitioners.
Well, not only is it important to listen to what they tell you, but then, you were supposed to be trained clinicians. Take it to the higher level. Then ask yourself, what did I just hear? What is the person's passion in life? What is the thing that really drives them? How can I tap into that? So when they say, they talk about their kids and the responsibility that they feel as a parent, fabulous. I am going to tap into all of that when I'm arranging a strategy to get them better. So to interpret what they say, and then other people say, oh, well, do you use a questionnaire? Hell no, I don't use a questionnaire. Those are for junior clinicians. They're repeatable questions. But if I say, do you have a good day and a bad day? Does your pain ramp up and ramp down? And if the patient says yes, that is a golden question. I know I'm going to be successful. They've just told me they have the ability to have a good day. Yeah. Fabulous. Let's find out the cause and build on what causes them to have a good day and wind down the things that are causing them to have a bad day within whatever the constraints of their life are.
And if they had said that they don't have those good days in amongst the bad days, there's still hope for that individual, right, Professor? It's just that, it's a bit of a deeper dig to find out what will relieve them and what won't, or desensitize them. Is that correct?
Yes, well said.
Yeah, okay, great. Let's move on to the rehabilitation side of things. In back mechanic, from my research, I believe you use that term, and you use it already in this recording, spine hygiene. Can you please unpack that a little, Professor?
Yes. Once we've documented what the specific pain triggers are, so the assessment will show us at the highest level what motions, postures, and loads, and then activities are triggering their pain. So let's take an example of a person who is extension pain driven. So in other words, I might lay them on a table and they arch backwards and they'll say, oh yeah, that causes my pain. And I say, well, what have you been doing? Oh, well, the therapist was giving me McKenzie push-ups or something like that. And I'll say, well, I guess I know why you have back pain. But, for some people, the McKenzie extensor program would be perfectly justifiable. And yet in others, it was their poison because they never got assessed to know. Yeah. But anyway, so let's say now they went into an extensor pattern with a bit of a rotation. Oh, yeah, there's my familiar pain. Well, now I'm going to say, sit on a stool. Now, I hope you can see my back. Now, they're sitting on a stool, and I'll say, stand up. Observe my back. Here's them standing up. Their first move is into spinal extension, and then they stand up. And I'll say, that created a little flash of pain, didn't it? And they said, yes, it did. How did you know? And I said, well, I just documented extension causes your pain, and I just watched you move. It's paradoxical. Why on earth would you move into extension? Now we have a discussion of software and hardware. Many therapists operate on hardware. So they might say, well, if we gave some thoracic extension, and it would reduce the need for you to move your lumbar spine into extension. So we'll move the extension responsibility elsewhere. We'll put it down in your hips and up in your thoracic spine. However, we move based on engrams. These are neural connections that represent movement. So if you and I walk, we don't think about our bodies moving as we're walking. We don't think about activating muscle. We just run a tape. So that engram resides actually in the spinal cord. My father used to tell me stories from World War II. He would see a mate with the head blown off, and the body would keep running until it hits something that would create a perturbation, and then obviously the body would fall. And if you've ever had a chicken for dinner and you went out to the back and got one and you cut its head off, the chicken runs perfectly until it hits the side of the barn wall. So there's an example of an engram. Now, that person whose first move into extension, was that a hardware issue or was it a software engram? Quite often it turns out that it's an engram, it's a habit. So that's a totally different intervention from a physical one. So we have to start, I might say we needed to write a new engram. Put your hands on your thighs, slide your hands down, and you will know this. Well, you're an Australian, so you know cricket. You will watch the cricket outfielders in this position. Now, stand up. But before you stand up, here's what I want you to think. Shape your spine into different positions so it doesn't cause pain. Now, leaning tower forward and carry more weight down your arms. And don't shrug, anti-shrug. Perfect. We've stiffened your spine now into a resilient position that doesn't trigger pain. Now, do not lift with your back because their brain engram is this. They move their spine into extension. What I said, now think, pull your hips through and drag your hands up your thigh. Now, practice this. When you brush your teeth, bend down and pull your hips through. Yeah. Reach forward and flush the toilet. In other words, you're creating a new engram. That becomes the default replacement engram. So now when they get off the chair, they don't go into that extension-driven pain trigger. So that takes more time than a physical corrective exercise. But there's just an example of recognize and measuring what their pain trigger is, watching them move throughout life. So we got on and off the toilet, we brushed our teeth, and we flushed the toilet. Every single one of those picked the scab and created more pain sensitivity. So we then showed them through a pattern of bending forward that didn't trigger the pain. That's spine hygiene. So we create that engram and show them how to get dressed in the morning and conduct their activities throughout the day in a spine-sparing way. Now, it may be they are flexion intolerant. Maybe they're compressive load intolerant. Well, again, whatever is triggering the pain, we then create a spine hygiene package for them to settle down the pain. It might involve a support, like say they have discogenic flexion-based pain. Well, if they sat with a lumbar support, they would find, I am not sensitizing that tissue now, and it winds down the pain faster. So there would be another example where we would use a device to assist in the exercise of spine hygiene throughout the day. But the whole point of it is to build training capacity. So now, all day long, they aren't getting into pain. Now they can go and train. You've just created a pain-free capacity. Now we build the foundation that they need for pain-free activity, and we get to work. We get to work on stabilization, mobilization, etc., and tune that body.
Brilliant. So spine hygiene, in essence, is desensitizing the pain to allow you to then get training, basically.
Yeah, you're obviously a very savvy, skilled clinician. So yeah, every time you just take my long-winded gobbledygook, and you and I should write a book together. You can just create that beautiful little thoughtful summary. Thank you.
Oh well, look, that's a great compliment. Thank you, coming from Professor McGill. Let's talk about the training side of things, the exercises. In back mechanic, I believe you reference the big three, and this is, McGill's big three that I certainly learnt as a university student, Griffith University here on the Gold Coast. I want to touch on those. Also want to touch on what you deem as, the silly exercises, and I know that there's a bit of a lighthearted nature there. But let's talk maybe about the McGill three, what they are, why they're important, and where do people start with them?
Okay, to give context to this, I have to describe what spine stability is.
Please.
May I do that?
Please.
And then I can talk all about the big three exercises and why they're non-negotiable.
And is this, to put listeners in perspective, this concept that people hear about and they see on social media about core stability, is this what we're talking about?
Exactly. So whether you use the term core stability or spine stability or trunk stability, this is what it is. When I ask people, explain to me what spine stability is, they're lost. So let me give you a measurable, quantifiable explanation of spine stability.
Brilliant.
Okay. All right. I will just start by simple concepts. The body is an articulated linkage. Right? Everyone's familiar with motion in real life is governed by Newton's 3 laws of motion, but they don't govern how this linkage moves. So if I want to wiggle my finger, I had to stiffen my wrist. If I didn't stiffen proximally, my hand would be all floppy and I couldn't isolate that motion. If I wanted to throw a ball hard, if I didn't stabilize proximally, my whole body would flop. It's like firing a cannon out of a canoe. You cannot do this. So now let me give a little bit more context. The torso, it's not a mystery why the top and the bottom has ball and socket joints. So we have shoulder joints and hip joints. As I've already shown you, these joints are designed to create motion throughout the whole range. Now, let me just take a shoulder joint. Say I could bench press 200 kilos. I can't, but say I could. I will never be able to use that bench press athleticism in real life because you can only bench press half your body weight standing and then you fall over. But let me say the bench press muscle primarily we'll say is pec major. It's just crossing my shoulder joint. Well, distal to the joint on the arm side, it creates flexion and the ability to push. But people forget it also has a proximal side. So proximal to its crossing of the shoulder joint, it connects to the rib cage, and the muscle action there bends the rib cage towards the shoulder. So if I just use my bench press muscle to push, I collapse. But if I create proximal stability, which is core, trunk, spine, whatever you want to call it, I stiffen it down, 100% of that muscle action now goes to the athletic effect. So consider walking. I might be a rugby player and I cut and turn. If I don't have proximal stability, when the hip muscles fire, they extend and externally rotate the thigh, but they also bend the pelvis the other way. So that wouldn't be a very effective cut and turn on the rugby pitch. I had to have proximal stability to lock down the core to get athletic expression on the distal side of both speed and power. So this is non-negotiable for transferring power to the limbs where the athleticism comes from. So that is the first tenet. It's non-negotiable. You have to have proximal stability to create distal athleticism. This is a model of the spine, and we've created compressive tension down the spine with just a wire. Now let me shape this column into a spine. So there's a lordotic curve and a kyphotic curve. Notice that spine, it can bear perturbations. I can push it around and it stays upright and standing. Now, your spine, if I took it out of you, as we do with cadavers, the spine buckles with 20 pounds or 90 newtons, 9 kilo, and the thing buckles. So you have to create a guy wire system around the spine to allow it to bear a load. So here you are, you're a new mom and you're picking your baby out of the crib at 2 a.m. for feeding. That's a very heavy stabilization requirement. And if you fail to stiffen the muscles, some new moms will say, oh, I felt a knife go into my back. Yeah. Well, we get that. But now I'm going to take the tension in the guy wire system away by slackening it, and watch what happens to the spine. It collapses. Mm-hmm. So we've measured this spinal collapse on video fluoroscopy in, as you know, in real lifters. We've actually filmed injuries. It was a nasty thing, but we were able to document that as a mechanism. And then the third non-negotiable requirement of stiffening the muscle is to engineer out the painful micro movements. So injury, and it doesn't matter where it occurs in the body, creates laxity. So any orthopedic physical therapist would move the joint, and they would either measure, see, or feel a laxity. Now, I don't have fantastic clinical hands. I would use a fluoroscope, and I would measure the joint displacements to a very high degree of precision. But I would measure that micro movement there, and then I would perform it on the person by doing probes of their spinous processes, and they'll say, oh yeah, there's my pain. Pain's not here, pain's not here. The pain is precisely right there. And then we will see it on a fluoroscope as to why. Now, push my fingers out, and I repeat the probe. Oh, no, doc, I don't have any pain. Good. We just proved that stiffening out that micro movement took their pain away. So every time we create pain, we then try the strategy to take their pain away immediately. Now, that's so empowering to the patient. They say, well, right away, oh, I've got it. I know what I have to do now to wind down my pain trigger. So I hope those three explanations, now I can go through the engineering descriptions, but that's a long lecture on how we actually put numbers on how stiffness enables performance of a flexible rod within this articulated linkage in a pain stress-free manner. So now I can talk about the big three exercises. We didn't create those exercises. They've been there always. But what we did was we measured people doing a whole wide variety of different stabilization exercises, and we measured which ones guaranteed stiffness and stability and did so in a spine-sparing way because these people have back pain. The three exercises that kept bubbling up to the top as the best ratio of spine-sparing to high stability index was three exercises for the front, the side, and the back. The McGill modified curl-up, as they call it, the side plank, and then the bird dog exercise. Then we trialed them on different groups of people with back pain, and once again, they proved superior. And then I'll read some other trials. We in our experiment, we did the exercise 3 days a week. We never said do them 3 days a week. In fact, you must do them every day. And some people need to do them twice a day. And the reason is we then took populations of athletes, for example. our recent study on Muay Thai fighters that was published. Now, where was that? I think it was in the Strength and Conditioning Journal. But the point was, when you do the big 3 exercises, neurologically, you get a period of extra stiffness and stability. In some people, it lasts 20 minutes. In other people, it'll last 2 hours. But the point is, they hit a little bit harder and faster when we measured their strike dynamics. We know that sprinters can run a little bit faster. There are many professional teams that start their training sessions with the big 3 because it creates a stiffer platform for the spine and more explosive hit power, for example. So I hope that gives a story as to why those are superior. Now, will it take you through to the Olympics? No, of course it won't, but it will create a stiffening pattern. When it's repeated, it replaces these engrams of inappropriate or non-existent muscle activity in the core or the torso, whatever you want to call it. So there's again, layer upon layer of science. And yet I'll have to tell you this just because you're Australian. I was at a very high level meeting of professional coaches 2 weeks ago. I won't tell you the league. But one coach, coaching some of the top athletes in the world, said, well, should we draw in to stabilize the spine? And I said, well, that came from a notion in Australia. Yeah. And I said, absolutely not. It will ruin stability. In fact, do you know of a single athlete who, under a heavy squat or speed, draws in their belly and sucks up their pelvic floor? And they do not. It is so inhibiting. Just run that experiment yourself, and you will find actually they don't. They stiffen the core and push out, if anything, and create pressure. That's how you enhance performance for speed and load, and as it turns out in the most basic form, to reduce pain as well. But it needs to be tuned because there's a compressive cost to that, and if the patient is compressive load intolerant, that will be an inappropriate over strategy. So we'll dial that back to a lower level. But anyway, never use the word transverse abdominis or anything like that. Just simply push my fingers out and tune it.
You're listening to an expert edition of the Physical Performance Show featuring Professor Stuart McGill, back biomechanist and world-leading expert on all things lower back pain and performance. If you missed last week's episode 107, featuring dual Olympians Julius Achon of Uganda and Eloise Wellens of Australia, then be sure to jump back and tune into this special episode. I had the ability and privilege of catching up with Julius and Eloise in person here at Pogo Physio only 2 days after the closing of the Gold Coast Commonwealth Games, and we discussed a whole raft of things, the highs, the lows and the learnings of their career, and they're coming together to found the Love Mercy Foundation. If you missed it, here's a little snippet.
Growing up in Uganda or in Africa was very tough. I grew up in a place where the war began in 1970 till 2007. So at the age of 10, the head of rebel commander came and recruited us from our village to go and serve in the war bush as a child soldier. So one morning they came and they kidnapped us or abducted us to go and fight. We were all given guns. So we walked 100 kilometers for 3 nights.
To tune into the full episode and explore the archives of the Physical Performance Show, be sure to jump over to pogophysio.com.au or simply peruse the archives from your favourite podcast player. But for now, let's jump back with Professor Stuart McGill on this, an expert edition of the Physical Performance Show. Let's talk about some of the sit-ups. Why sit-ups can be so deleterious for spinal health. The compressive force, I believe, with a sit-up is up to 3,400 newtons. It's huge. And yet, why is it, Professor, that we still see these being done in all manners of life, recreationally, in professional sporting outfits, and even in the military. What's the barrier there to people understanding that sit-ups just aren't an effective way to produce any stabilisation, stiffness around the lower back, the spine?
Well, you've asked several layers of questions there, but I appreciate them all. Let me just start with a little bit of background. First of all, people have to understand how news is created. And if I wasn't in the news, I wouldn't understand myself. But yes, I've been quoted as saying McGill is the man who wants to kill sit-ups and crunches and all this kind of thing. These are newspaper writers sensationalizing science. I would never say such a thing, obviously. So having said that, every exercise is simply a tool to reach a goal. So you have to know the goal and then go and choose the best tool or exercise to reach the goal within knowing the person. What is their current capability? What's their injury history, etc. So there's a little bit of a background. Now let's have a discussion about sit-ups. A sit-up obviously challenges the abdominal wall, but it also challenges the hip flexors as well. You may want to do both of those things. You may have no history of back pain. You may be a slender spine. Why do I say all these things? If you take a slender willow branch and bend it back and forth over and over again, it doesn't create stress. There's no real problem. But if I took a thicker branch and bent it, it would shatter right away because the stress in a radial tube is a function of its thickness. So if you took a big Australian rules football player, heavy-framed player, and then you took a thin-boned gymnast with lots of spine flexibility, then do a trial of sit-ups in both of them. What you will find is the gymnast may not have any consequence, but the heavier-boned rugby player or the big NFL lineman, offensive tackle playing professional football in the U.S. will get pain very, very quickly. And if you don't believe me, do this experiment. Put an Olympic bar on your back and simply bend back and forth doing a pelvic tilt. And the thicker the spine, the faster they will get back true disc pain discomfort. So, there's nuances within nuances of all of this. But having said that, the average person does generate about 3,400 newtons of compression. Is that what you really want, and was that the best tool? Were you doing sit-ups to look good on the beach and create a six-pack? Well, if that was your reason, that was the wrong exercise, because when we quantify sit-ups, the six-pack, the rectus abdominis, it only contributes less than 20% of the torque to create a sit-up. Most of it comes out of the oblique wall, and the forces get redirected down the fascia of rectus abdominis. So to do side planks, rolling side planks, these kinds of things, they would be better off for creating the six-pack if that's what they wanted to do in a way that increased training capacity. Sit-ups will use up a lot of your training capacity. Every system in biology has a capacity. If you're below the tipping point, it will build you. But once you cross the tipping point, the tissues now start to become overloaded and they actually break down. So you can use up a lot of training capacity doing sit-ups if you wish, but do our way and build training capacity in a mindful way through spine hygiene, doing the big three, avoiding sit-ups. Now, maybe you were doing sit-ups for hip flexion power, but there's a lot better way to create hip flexion power, for example, than doing a sit-up. So that's the start of the mechanical side. Now we can get into the very interesting history and politics, which is what you alluded to with the military. The U.S. military is an example where all the soldiers and sailors and airmen every year had to pass a fitness test. And part of the fitness test, for historical reasons from World War II, were speed sit-ups. How many sit-ups do you do in a minute? Well, soldiers need to pass the test, so they train the test. Every day they will do sit-ups for a minute to make sure that they can get the score. Well, they were finding the number one reason for soldiers returning home from, what was the war? The Desert Storm War, I forget.
Gulf War.
The Gulf War. The number one reason for American soldiers returning with back pain was from doing the fitness test. It wasn't because they were damaged with ordnance or fire. So that caused the military to say, is there a better way? So I was actually a consultant on that. But the American military is a strange beast. It's so huge, they don't talk to one another. So I believe there's the Army, the Marines, the Navy, etc. The Navy is now going through the process of changing their speed sit-up requirement into a front plank holding time. But that's a bit of a problem too, because the front plank holding time is based on your shoulder integrity, and if you've got sore shoulders, you won't do very well. But they couldn't use a test that required equipment, because every military base and ship and airplane, etc., would need equipment for the test. So these are the politics of how it all works. But to finish that interesting story off, another branch of the U.S. government is NIOSH, the National Institute for Occupational Safety and Health. They have exposure limits for hazards to the American public. One of the hazards, believe it or not, that they list is low back compression. You can guess what the exposure limit. I didn't find this, although our work does confirm this. What is the level of back compression that increases the risk and subsequent prevalence of back pain in the American public? It's 3,400 newtons. Guess what the load that is placed on the spine in the average American doing a single sit-up? 3,400 newtons. So here you have one branch of government showing that through epidemiology and quite a wide range of scientific experts converging on this limit of 3,400 newtons, and then you have another branch of government, the military, violating it in their fitness test. So you can imagine the litigation and the legal process, and this takes an act of Congress to change the fitness test. It's an amazing beast, but it's been a little bit of fun to work on. But again, welcome to my world. But the member of the public and the clinical world has no idea of the complexity of something like a discussion on sit-ups. But just to reiterate, let's get it back to the listener of your podcast. They are trying to enhance their athleticism and their joy of life, but they've got back pain. Know the goal. What is it that they're trying to achieve? That comes from the assessment, and then choose a tool to reach that goal in the most spine-sparing way, build capacity, and then get to work. And what they will find is most of the time that is not a sit-up.
Brilliant. And getting to work outside the big three, which hopefully have started post, or obviously it's not mutually exclusive, spinal hygiene and then getting to work. They sort of, there's no definitive endpoint, they morph. But getting to work outside the big three, things like, I know you're fond of kettlebell work, any exercises, and it's always based on an individual's goals, as you say, and their assessment findings. But what are some of the exercises that you found really advantageous, Professor, to help people, get back to their physical best?
Right. Well, the answer. The answer is it depends. So what I would give to a Brian Carroll is not what I would give to an Olympic sprinter, nor would I give it to a new stay-at-home mom with they've got one kid in diapers and another who might be 4 or 5 years old and requires to be picked up and that kind of thing. So it all goes back to the assessment and knowing the goal. So having said that, just an average progression, it might be go to a front plank instead of a sit-up. Then they might want to do stir the pot. So it's basically the elbows are on a gym ball or one of those yoga balls, whatever you want to call them. Some people call them a stability ball. They're absolutely not. They're actually a mobility ball, but that's another discussion. But to do stir the pot, the toes are on the ground, and you can just do little circles with the elbow. So if I'm preparing a mixed martial artist for a contest in the UFC, they might do stir the pot for 5 minutes, 1 minute off times 5. Now you'll know if you're ready for that level of physical contest. I might do ballistic, explosive work out of a stiffened core to unleash the hips and shoulders. Those would be in the explosive athletes, the sprinters, some MMA fighters, etc. So, again, you've given me such a huge spectrum of the human condition here, but there might be a little bit of a start. And for me to choose any single exercise, I always need to know the full program, because sometimes there's duplication of achieving that goal. For example, the person, maybe they're doing deadlifts, and then they're doing squats, and then they're doing split lunges. And I'll say, you will be a better athlete if you go and push the car back and forth through that parking lot. We've got it all. So there might be an example where I can create efficiencies through programming, replacing several exercises, and I can achieve higher athleticism in a shorter period of time with a single exercise. It's a bit off topic, I know, but this is a cerebral process. Yeah. Creating a program, it requires every ounce of my the neurons between my ears. It takes every ounce. This will surprise you. It takes every ounce of my emotional ability as well. After I'm finished with a session with a person, I'm exhausted. I've given them everything I possibly have to come up with the wisest way to desensitize their pain and then build them all back up again. It's a very, very difficult thing.
And I appreciate that as a clinician. And I think unless you do feel like that in the work, then you possibly are chasing the wrong call in or profession. And I know with back mechanic, and for listeners that are listening in, they've gone around the merry-go-round of, unsuccessful breakthrough with rehabilitation. They're still in pain. They've seen multiple practitioners, and maybe they're quite disillusioned. I think it's important to note you have done the work in putting together Back Mechanic. It was a 4 or 5 year process. You've referenced it as the hardest publication you've ever produced. Be encouraged. You've put it into a very systematized, structured manner that will be able to take them from low function to at least some very good function, and on top of that, they then might want to engage the services of someone that is wise and a good steward of their backs with exercise prescription. Would you agree?
Yes.
Yeah, great. No, great. And obviously that's not just a blatant plug for the book, but you've put the work into simplifying what is, as you say, a very complex individual type condition that is really difficult to systematize and put structure around.
Yeah, I had a book agent who approached me and said, "Can I sell this book for you to the big publishing houses?" Every single publishing house came back and said, "This won't sell. You have to have a title, Cure Your Back Pain in 5 Easy Steps." And I said, "That's a lie. I cannot do it. It's a disgrace to myself and to the public. So to hell with them, I just did it myself." So it's actually 17 chapters, describes the pathways of pain and how the spine works in a consumable way. You can read the reviews on Amazon.com. That will help anyone who's in doubt. I know the Australians are skeptical people, and they don't fall for marketers. And then I take the reader through a self-assessment of their back pain, and then show them the principles of spine hygiene, how to build strategic mobility and stability, and then move on to patterns in pushing and pulling and carrying, etc. Now, that's all designed to get you out of pain. Once the person is out of pain, they can transition to the book that you bought, which, by the way, Brad, is now in its 6th edition, not the 2nd. But look, I'm going to send you all these books, by the way, so don't worry.
Oh, thank you.
So now it's time to change the game and put together a program to restore some athleticism. And for the real strength athlete, there's a gift of injury, which when I first started writing this with Brian, it was just about his story. But then I discovered Brian could write. And he's obviously become a wonderful friend. But the book then became a manual on restoring strength, and he gives his programming necessary to lift over 1,000 pounds. And the last little bit is a little bit on nutrition, what's in his gym bag, what he thinks before going into a meet. Some real hard-won wisdom that comes from the trenches that people don't hear every day. But then, you know, the big clinical textbook that I wrote for clinicians, low back disorders, is, again, it's a very heavy textbook. It's not for the lay public, but the clinicians will probably enjoy that because it really gets into the nuts and bolts of the assessment.
No, look, brilliant. So, and where can listeners find, you know, the books? If they're listening in Australia, I believe it's elixir.com.au, and we can certainly tag this up or put this in the show notes. Elixir, elixr.com.au. If you're outside of Australia, obviously Amazon, Professor McGill is where listeners can pick up a copy of The Back Mechanic.
Yes. Our website, backfitpro.com, it has an Australian flag on the books page. So if you just click on the Australian flag, it will take you to Elixir, okay. and they can't spell. It's actually that, if you can read it, ELIXR. .com.au/education/backfitpro, but they're my rep for selling educational material in Australia. But as I said, if you just go to backfitpro.com, they can find the flag of whatever country they're in and be able to find that material.
Brilliant. So we'll certainly, listeners, tag that up in the show notes, backfitpro.com, and you can find all the resources there. Just finally, a few final questions here, Stu. I know, Professor McGill, after this you jump onto another interview, so I want to honour your time, but if you could just briefly touch on the 24-hour response of the spine in terms of why is it that people get in the car at the end of the day and they need to adjust their rear view mirror?
Well, discs are hydrophilic, and what that means is throughout the night, the discs imbibe fluid. They are a little bit swollen first thing in the morning. When you measure the stress of bending first thing in the morning, in other words, people will feel this when they take their socks off at night, their spine bends freely. But when they put their socks on in the morning, their spine is stiff. The mechanical reason for that is the bending stress is 3 times higher first thing in the morning if you stayed in bed for 8 hours. So avoid, if you have back pain and bending back pain, bending first thing in the morning. And that was trialed by Professor Snook at Liberty Mutual Insurance in the US. Avoiding flexion bending in the morning, on average, reduced back pain, which was the clinical trial to prove the principle. But throughout the day, the discs loses fluid, and it loses 90% of the fluid in the first hour of waking. Wow. So another experience that people might have, say they have a pneumatic lumbar support in their car. They'll be driving to work, and they'll find, oh, that's overinflated. So they have to let a little bit of air out, because in the morning, their spine doesn't need so much support. It's actually a bit swollen. And then when they get in their car, at the end of the day, they'll think, oh, my lumbar support is leaking air. Actually not. They've now got a more flexible spine because of the hydrostatic pressure squeezing fluid out throughout the day. So they'll find they'll need a bit more support. But again, we tune the time of their training sessions and whatnot. It's that degree of precision to get a difficult, challenging back better. But absolutely, there's a diurnal variation to stress, stiffness, and injury resilience.
And Professor, I've certainly found as a clinician that just those basic education principles for someone about what they can expect in the nature of their day-to-day, imbibition of their discs is empowering. Okay, it's okay if I feel a bit stiff in the morning, so thank you for sharing. Finally, Professor Stuart McGill, leading back biomechanist, low back pain expert. What is your physical challenge going to be to listeners of the show for the week?
You warned me about this, Brad. So it really goes against my philosophy to give a general instruction. However, I will not shy away from this. The body, for good health and a good back, must walk. It's non-negotiable. So my challenge would be walk 3 times a day. We usually try and coordinate that with mealtime, breakfast, lunch, and dinner. Go for a good fast walk, 15 minutes, 3 times a day, and your back will be happier.
Brilliant. And I've heard you say you need to own the world when you walk, right? You need to give it a bit of swagger.
Absolutely. It's so interesting. There's some people, and I might say there's a few in Australia who say posture doesn't matter. Oh, my goodness. It's so interesting when a person comes into the clinic, their head is forward, their shoulders are slouched, and they'll say, Dr. Beer, I've got back pain. Well, no kidding. Just palpate their erector spinae and they're rock hard. But when they pull their head up over their hips, they pull their shoulders back, all those muscles just relaxed. And for the first time, they'll say, oh, that was magical. You just took the pain out of my back muscles. And no, you didn't. You just relaxed them through a posture change. Now, walk like you own the world. And instead of this crippled, bent over gait. And you know what's so interesting, Brad, is when you talk to criminals and people who cause physical violence on others, they know their mark. They know the mark by the way that victim walks and their posture. They don't attack people who walk with attitude like they own the world. They attack people who look like victims, who do not own the world and are beaten down. And part of our job is to get that emotion in people that they are in control, they're empowered, they own the world, they own their pains, and you liberate them and you use all your best science and knowledge to empower them.
Professor Stuart McGill, on that note, thank you for so generously sharing.
Brad, I should be turning that right around. You're very good at what you do. I do a lot of these, and you actually brought out of me today things that many fail to do. So thank you very much for that. You're good at what you do.
Well, thank you. So, there you have it, another episode of the Physical Performance Show. I trust you enjoyed today's episode featuring Professor Stuart McGill. If you did, then please let both myself and Professor McGill know. You'll find us over on social media at Brad_Beer and at BackFitPro for Professor McGill on Instagram. He's very easily found on the net over at backfitpro.com. Backfitpro.com is a wonderful archive of all of Professor McGill's work, and if you are a clinician, you will find great helps there. If you are a back pain sufferer looking for more information about Professor McGill's many books or his other great resources, and jump over to backfitpro.com. If today was your first time tuning in to the Physical Performance Show, then a mighty welcome. If it was your 108th time, then thank you for your ongoing support. If you've enjoyed today's episode and know someone who would benefit or enjoy this expert edition, then please share it with them. Sharing means an enormous amount to myself and also the featured guests of the show. Don't forget also to hit subscribe if you would like to get each and every episode of the Physical Performance Show auto-updated into your device each and every week as they go live 9 p.m. every Thursday evening. If you've been enjoying the Physical Performance Show, then please consider leaving a rating or review over on iTunes. You can do that now from your smartphone by simply heading over to iTunes and clicking rating and review and rating away. 1 star if you think the show's okay, 5 stars if you've been really enjoying the Physical Performance Show. A massive thank you this week to one faithful listener who took the time to leave a review, and that is long-time listener and up-and-coming 70.3 Ironman triathlete, Lindsay Laurie. Lindsay commented, "My favourite podcast, 5 stars. Brad's unique questions let you really get to know the guests' personalities and how they think. Such a great podcast for younger people who are keen to learn more about their idols and how they become who they are today." Lindsay, thank you very much for your ongoing support of the show and also for taking the time to leave a review. A big thank you to the team who make this podcast possible. Susan Wilkin on all things show administration, Matthew Olding on all things graphic design, and Daryl Misson, our amazing audio engineer. Of course, another big thank you to the show's sponsor, the Gold Coast Marathon. The Gold Coast Marathon support really does make this show possible. Podcasts are obviously free to download, however, they are not free to produce. And if you are yet to experience the wonderful weekend that is the Gold Coast Marathon, the first weekend in July on the beautiful Gold Coast, then do not miss it. There's many events to choose from: the marathon, half marathon, 10-kilometre road run, and also the 5.7-kilometre race. So jump over to goldcoastmarathon.com.au. If you are planning to run the Gold Coast Marathon, then we have a team for Pogo Physio. Each year we get together up to 100 runners and we have a great time. There's lots of perks: a safe and secure tent for all valuables close to the finish line, race day physio and massage, and lots of great products and gifts from our excellent and generous supporters of Pogo Physio. If you wanted to sign up for the Pogo Physio team for the Gold Coast Marathon, then simply select the Pogo Physio team and use the pin Team Pogo, all capitals, one word. We'd love to see you at the Gold Coast Marathon in 2018. Feedback helps us to make this show better, and we've opened up a mechanism to get feedback from you. There is the Physical Performance Show quiz, which is now available over at pogophysio.com.au/podcast. Now, if you head over there and leave your feedback, good, bad, or ugly, then you will go into the draw to win a $100 movie voucher for any cinema of your choice. We've got the quiz open right through until episode 115, so be sure to jump over and leave your feedback for the Physical Performance Show. You can also reach me over at b.beer@pogophysio.com.au. Don't forget to take your podsy. That's a screenshot of the episode you're listening to and enjoying, and share it on social by simply tagging me in at Brad_beer to win a signed copy of my Amazon running and jogging bestseller, You Can Run Pain Free. A big congratulations to Kelly Crowley over at on Instagram at run_till_your_done, who posted an image of herself enjoying episode 105 featuring Olympic triathlon champion Gwen Jorgensen. Kelly, so pleased you enjoyed the episode and enjoy your very own signed copy of You Can Run Pain Free. Coming up on next week's episode of the Physical Performance Show, I bring you a very special conversation that myself and fellow Pogo physiotherapist Lewis Craig had with best-selling author Matt Fitzgerald. Matt Fitzgerald is the author of many best-selling books, including Racing Weight, Run, the Mind-Body Method of Running by Feet, Brain Training for Runners, 80-20 Running, and Diet Cults. His book Iron War was longlisted for the 2012 William Hill Sports Book of the Year. Matt's a regular contributor to Men's Fitness, Men's Health, Outside, Runners World, Bicycling, Running Times, Women's Running, and many other publications. However, it is the authoring of one of my favourite all-time books around physical performance, titled How Bad Do You Want It? Mastering the Psychology of the Mind Over Muscle, that had me wanting to bring you a conversation direct with the author. Now, if you are into pursuing and performing at your physical best, and I know you are if you're tuning in today, then do not miss next week's episode featuring Matt Fitzgerald. We dive deep into all things mental fitness and toughness and how to close the gap to your physical best. So until next week, keep pursuing your physical best performance. I'm Brad Beer, and this is the Physical Performance Show.